Okay, yes, thank you. Yeah, the presentation was supposed to be given by Pernilla Elming. Unfortunately, she's back in the clinic and they wouldn't let her get free, so she couldn't make it. She was disappointed. As you can see from the title, the idea was to ask the question, can the combination of hyperthermia with low LET radiation have an equivalent anti-tumor effect as seen with high LET radiation alone? And I'd like to thank the various co-authors that are associated with this. Again, I'd like to acknowledge the technicians that did most of the work and the funding bodies that supported it. As I said in an earlier talk, hypoxia is a characteristic feature of solid tumors, shown up here, and there's good clinical evidence using the Eppendorf electrode that if you make measurements in head and neck cancer patients prior to therapy, you can actually separate the patients into those that were more hypoxic or less hypoxic, and those that were more hypoxic did worse. It's because hypoxia is a resistant factor to radiation therapy. You see similar effects in cervix cancer patients that receive surgery, which means that hypoxia didn't influence the treatment, but it influenced malignant progression. And as I said earlier, there's a whole range of different ways of dealing with hypoxia, and they're listed here. Hyperthermia, again, as I said earlier, comes up in most of those. But probably one of the best treatments is high LET radiation. And the reason for that is illustrated here. What we're looking at is linear energy transfer compared with the oxygen enhancement ratio. This is from some old study back in 1968 from Baronson and colleagues. And what you have up here is a survival curve for cells under aerobic conditions, well oxygenated, or hypoxic conditions. And you can see that when you look at a particular level of survival, you typically need about 2.5 to 3 times the dose under hypoxic conditions to kill the same number of cells. So the oxygen enhancement ratio, when you compare this dose to that, is around 2.5 to 3, and that's what you get down here. But when you start to increase the linear energy transfer of the radiation, you can see those cells begin to come closer together, so the LET goes up and the OER goes down. And it was suggested if you can get the LET high enough, hypoxia is not an issue. In fact, more recent data shown here suggests that even when you have high LET radiation, there's still a factor in terms of hypoxia resistance. So this curve doesn't actually come to here, it's probably around here. But it's certainly very good at getting rid of hypoxia or reducing the effectiveness. And so there's been suggestions that maybe the biggest problem, of course, if I go back here, is that there are very few carbon ion facilities in the world. I think the last estimate was 13 facilities, of which nearly 70% are in Asia. So the likelihood of you getting treated in a carbon ion facility is pretty remote. So we've got to try and find ways of getting around that. And one of the ways that's been suggested from the Swiss group is that if we combine hyperthermia with proton irradiation, we can mimic carbon ion therapy, perhaps. And this is the study that they proposed, the HyperSAR study, where they're giving radiation therapy and they're giving hyperthermia treatments. They're aiming for temperatures about 41.5 to 42.5 degrees for 60 minutes, with an interval about 90 to 150 minutes. And the question is that good enough? And that's something we wanted to look at. Because the big problem is there's not a lot of preclinical data out there to support the arguments. I think it's a great study, but the real only data is in vitro data where they actually compared photons with hyperthermia and see if it was as good as carbon ion. So we actually want to go ahead and try and repeat this sort of study, try and do something in vivo. Unfortunately, our proton facility isn't up and running yet, so we've had to rely on photons. So what we've done is we've taken this mouse model that we have, it's a C3H mammary carcinoma, we grow it in the foot, we restrain the mice, and we can turn the jig on its side, and you can put the mouse's foot down into a water bath to heat it. And then you can irradiate from the side and shield the animal, so the animal itself is protected. This is some data we've produced. We like this model because we can do tumor control, which is the only really clinically relevant endpoint. This is showing percent tumor control as a function of dose when we give radiation photons, or if we give carbon ions. And to do those experiments was very difficult. We had to implant somewhere like 300 mice and drive them down to a facility in Germany. And what you find is when you look at the TCD50 value, the radiation dose to control 50% of the tumors, the difference is about 1.5. So the RBE for carbon ions is about 1.5. Then we set up some experiments. We said, okay, what do we see if we give radiation and heat? And we used two situations. We gave a simultaneous heat and radiation treatment. These were the temperatures and the heating times, or we have a sequential where we give the heat 4 hours after with these temperatures and times of heating. And you produce data like this. Again, this is tumor control as a function of radiation dose, radiation alone, or radiation and heat. And as I showed earlier, you get this sort of curve. If you give simultaneous heat and radiation, you get the best effect. If you allow a 4-hour interval, the effect drops off in the tumor, and you can look at the enhancement ratios by comparing these sort of data for this simultaneous or sequential treatment. And you can plot these enhancement ratios on this figure, and that's what's shown here. So here we have a simultaneous heat, different temperatures, where we're heating for 60 minutes. So we're radiating in the middle of the heating period. And you can see the higher the temperature, the bigger the effect. What's on here is the dashed line for carbon ions, 1.5. And you can see that with a simultaneous heat and radiation treatment where the heating is for 60 minutes, you only need a temperature of 41.5 degrees to get the same effect as you see with carbon ions. If you heat for a shorter period, of course, you need a higher temperature. If you have a sequential, where you're having a 4-hour interval, you can see you need a much higher temperature to get the same effect of carbon ions with a 60-minute heating. If you actually go for 30-minute heatings, it's almost impossible to get up to that. So the clinical study that's being proposed is in the right temperature range, but you certainly do see a difference depending on whether you're giving a simultaneous or a sequential treatment. We took it one step further. We've got interest in the use of so-called vascular disrupting agents. These are agents that damage the tumor vasculature from which these tumor cells get their oxygen nutrient supply, and that causes a blockage and kills the cells. And there's a whole range of agents that can do that. We focused on this compound here, oxy-4503, which is an analog of combratastatin, and it's in clinical development. It works very nicely when you combine it with radiation or heat. And then we looked at what happens if you put it together. So what we're doing is we're giving oxy-4503 1.5 hours before we irradiate, and then we heat either simultaneously with the radiation or up to 4 hours after. And we're only using mild temperature hyperthermia. These are the dose response curves you get, and this is the TCD50 values that you get from this data here. So this is the shaded areas radiation only. You can see oxy on its own has a small effect on the radiation response. The open symbols is heat and radiation together without the oxy. And here you see that the best effect, again, as we showed earlier, is a simultaneous heat and radiation treatment. When you introduce an interval, the effect begins to drop off, but it never comes all the way back to here. So it flattens out. If you give oxy and combine it with radiation and heat, you don't actually see any effect on the simultaneous, but what you actually prevent is the drop-off. So a 4-hour interval is just as good as giving it simultaneously. This is actually skin data, and typically, as you see, what you see is oxy doesn't have any effect in skin. Heat alone has a big effect on radiation with a simultaneous. It's just as good as what you see in the tumor, but as I said earlier, it actually drops off here. But what's interesting is that oxy doesn't change that response. So now you can go back to this data and actually plot the oxy radiation and heat, and we've only done the 60-minute heating on this curve, and you can see it doesn't change anything, so it doesn't matter. But what it does in the sequential is actually moves this across to there. Has a big effect there, and it's actually giving you a value that's exactly the same as that. So our conclusions: photon irradiation and hyperthermia can induce the same local tumor control as carbon ions, but the temperature at which this equivalent response occurs depends on the radiation and heat sequencing. For a truly simultaneous treatment, one only needs a mild hyperthermia temperature of 41.5 degrees. In a sequential schedule, temperatures of 42.5 degrees and above are required. However, if VDA is included in the treatment schedule, temperatures of only 41.5 degrees are needed. And I think that's the last slide, and I say thank you. It's not on.
very much for your presentation. Are there any questions for the audience? Please.
Well, let me first thank you, Michael, for this excellent presentation. And moreover, it really convinces that whatever we proposed 3 years back perhaps is also being reflected in the in vitro studies. So it's really nice to have a collaboration between the clinical trials that we propose and also have a backup from what is actually being seen in the labs. The only one thing which I would point out, yes, I do agree that there is a temperature dependence. But what we experienced clinically when we were treating these patients, always, although we would be trying to shoot to the maximum temperature, but it all depends on the patient tolerance. Many a times we can go up to 40, 41, 42. So that's something which we can't really control. We have to respect the patient's tolerance. So that's the only thing which I just wanted to add.
I don't disagree with you there. I mean, the same with anything. You're treating to tolerance, whatever you're doing, even with the radiation treatment. My argument is that in your trial itself, you're saying 41.5 to 42.5 with a 90 to 150 minute interval. The 41.5 is on that limit, I would think, based on what we say. And ours is different. Yours is a fractionated schedule. You combine it with protons. Protons have an RBE of 1.1, so the effect is going to be better than you see with photons. But it's fractionated, and that's going to reduce the effectiveness. But I think if you're only going to get 41.5, you're on that point where maybe there's not really any benefit. If you can get above that to the 42.5 that you suggest, you're definitely in the right range. So I think you've got to be careful. And I know there's an issue with patient tolerance, but I mean, if you're only getting 40 degrees, 40.5, I don't think there's any benefit, personally.
Treatment as close as possible.
Sure.
But actually the PSI and our hospital, the travel distance between these two have to be taken into consideration. So that's where the 90 minutes gap is kept.
Yeah, and I don't disagree, and I understand the limitations. There's a lot of argument about mild hyperthermia is the way to go. That does it, okay? If you look at all the clinical trials that everybody got mild hyperthermia treatments, but not every trial worked. The only ones that seemed to work were those where they actually got higher temperatures. And that's one of the arguments I've always put forward. We need to go for the higher temperatures if you can and get up there. You only need a few good heat-ins in the regions where you have the poor perfusion, the hypoxic regions, to have a significant benefit on response.
And there's also another aspect of this, because in clinic we don't heat before every radiation fraction, but in the model we are treating this LET, mimicking carbon ion treatment, as if we had also the every fraction of low lead radiation with hyperthermia.
The preclinical study is just one heat treatment with one radiation treatment. It's a limitation. What we need to do is go over to fractionated, and we need to go over and do protons to see what happens. Yeah, but it's suggestion, and there is a relationship between, even though it's single studies, there's some good data. I mean, our single studies in this model fits very nicely with what was shown by Jens Overgaard in the melanoma trial. The data is very, very similar. Where they use the fractionated schedule, it comes out very similar. So it's a model.
We must move forward.
But we need to.
Thank you very much. There are a lot of questions, but we've also